While extracting a mandibular third molar, you notice that the distal root tip is missing where it's most likely to be found. It will be found in the submandibular space. Important to prevent this, avoid all apical pressures when removing the roots of root tips or root tips of a mandibular molar. If a mandibular molar root tip is displaced inferiorly, it may either be in the mandibular canal or through the lingual cortical plate. It may either be, The mandibular canal is generally found buccal to the roots of the mandibular third molar. The submandibular space is a potential space of the neck bounded by the oral mucosa and tongue anteriorly and medially. The superficial layer of deep cervical fascia laterally and the hyoid bone inferiorly. The mylohyoid muscle stretching across the floor of the mouth serves as the inferior boundary of the sublingual space and the superior boundary of the submaxillary space. The mylohyoid muscle stretching across the floor of the mouth Okay, so note the submaxillary, submental, and sublingual spaces are collectively referred to as the submandibular space. The submaxillary space usually drains infections from the mandibular bicuspids and molars because their apices lie below the mylohyoid muscle attachment. This submental space is the medial part of the submaxillary space. It is, however, important to note that it lies above the mylohyoid, unlike the submaxillary space. It contains the submental lymph nodes that drain the medial parts of the lower lip, tip of the tongue, and the floor of the mouth. It usually drains infections from the mandibular incisors in canines because their apices lie above the mylohyoid muscle attachment. The sublingual space is the superior part of the submandibular space, containing the sublingual gland and loose connective tissue surrounding the tongue. Remember, Ludwig angina is the most commonly encountered neck space infection. It involves the sublingual, submandibular, and submental spaces. Arrange the following 5 phases of healing of an extraction site in their correct order. So I just read about this. Let's see if I remember that. So recontouring of alveolar bone and bone maturation should be about the 4th. Replacement of granulation tissue by connective tissue and epithelialization of the site, that would be about 3rd. The first one should be hemorrhage and clot formation. Okay. The first one should be hemorrhage and clot formation. Hemorrhage and clot formation, then organization of the clot by granulation tissue. That should be the second one. Then replacement of granulation tissue by connective tissue and epithelialization of the site. Then replacement of the connective tissue by fibrillar bone, and then recontouring of alveolar bone and bone maturation. Yes, so 5 phases of healing of an extraction site. 1. Hemorrhage and clot formation. 2. Organization of the clot by granulation tissue. 3. Replacement of granulation tissue by connective tissue and epithelialization of the site. 4. Replacement of connective tissue by fibrillar bone. And 5. Recontouring the alveolar bone and bone maturation. Now, glucocorticoids have been shown to have the greatest effect on granulation tissue. They retard healing. This is believed to be due to the fact that glucocorticoids interfere with the migration of neutrophils and mononuclear phagocytes into the site of inflammation. The phagocytic and digestive ability of macrophages is also reduced. Glucocorticoids inhibit formation of granulation tissue by retarding capillary and fibroblast proliferation and collagen synthesis. The same stages that occur in normal wound healing of soft tissue injuries also occur in the repair of injured bone. Again, the same stages that occur in normal wound healing of soft tissue injuries also occur in the repair of injured bone. However, osteoblasts and osteoclasts are also involved in repairing damaged bone. Bone healing occurs by 2 ways. 1. Healing by first intention, which is a primary union. And 2. Healing by secondary intention. In case of healing by primary intention, there is not much loss of cells and tissues. The end of the flap will approximate in some time, and the tooth extraction recovery will occur in some time, whereas in case of healing by secondary intention, there is extensive loss of cells and tissues. The end of the flap don't approximate, and the healing occurs from bottom to the top and from margins inwards. Healing by secondary intention is slow as compared to faster healing by primary intention. If a subcondylar fracture occurs, which of the following muscles will replace the condyle both anteriorly and medially? Okay, a subcondylar fracture. Subcondylar fracture. It would be probably the lateral pterygoid muscle. Wait, lateral pterygoid. Yes, it would be the lateral pterygoid. The muscles involved in displacing mandibular fractures include the medial and lateral pterygoid, temporalis, masseter, digastric, geniohyoid, genioglossus, and mylohyoid. The lateral pterygoid displaces the condyle anteriorly and medially because of its insertion on the pterygoid fovea. Muscles attached to the ramus, i.e. temporalis, masseter, and medial pterygoid, result in superior and medial displacement of the proximal segment. As fractures progress anteriorly toward the canine region, the digastric, geniohyoid, genioglossus, and mylohyoid exert a posterior inferior force of the distal segment. The lateral pterygoid muscle is the only muscle that inserts directly on the neck of the mandibular condyle. In the subcondylar fractures, the forces of this muscle frequently result in anterior and medial displacement of the condyle. In higher condylar fractures and in intracapsular fractures above the insertion of the lateral pterygoid, the small fragment can occasionally be seen displaced in a pure horizontal or vertical direction. Note, displacement of the proximal segment of the condyle usually occurs in an anteromedial direction because of the pull of the lateral pterygoid muscle. The patient will deviate to the side of the fracture on opening because the unopposed action of the contralateral pterygoid muscle. What of these options are second only to nasal fractures in frequency of involvement? Zygomatic fractures, Lefort 1, Lefort 2, and Lefort 3. It seemed kind of obvious, the zygomatic fractures, but I didn't want to say it because it was like too obvious. Well, but at the same time, anyway. Zygomatic or zygomatico-maxillary complex fractures involve four major processes, which is the zygomatico-frontal region, infraorbital rim, zygomatic buttress, and zygomatic arch. Zygomatic fractures are commonly encountered in facial trauma because of their prominent position on the facial skeleton. The most common mechanism producing facial fractures is auto accidents. About 70% of auto accidents produce some type of facial injury, although most are limited to soft tissue. The face seems to be a favorite target in fights or assaults, which are the next most common mechanism. Specific terminology is used to describe the different types of fractures that occur. Simple fractures are closed, while compound fractures are open and exposed through a wound. A comminuted fracture occurs when the bone has broken into multiple pieces. Fracture type prevalence. Zygomaxillary complex 40%. Fracture type prevalence. Zygomatico-maxillary complex is 40%. Lefort 1 15%, 2 10%, and 3 10%. Zygomatic arch only 10%. Alveolar process of maxilla 5%. Smash fractures 5%, and other 5%. The maxilla and mandible are in a critical relationship to the upper airway. Therefore, displacement of fractures can cause obstruction of the airway, resulting in respiratory arrest. Control of the airway is vital to any treatment of a patient with facial structures. Maxillary fractures have a greater tendency toward the production of facial deformity than do mandibular fractures. Maxillary Lefort fractures, orbital fractures, and zygomatic fractures usually require internal rigid fixation. The highest incidence of fractures occur in young males between the ages 15 and 24. These fractures are usually the result of trauma. The most frequent complication associated with mandibular fracture management is hematoma, wound dehiscence, facial trigeminal nerve injury, or infection. Man, I would say nerve injury. No, infection. I really didn't. I thought the nerve injury in the mandible was more common. Because if you're giving the patient antibiotics, you shouldn't have an infection, or at least not as often as a. It depends on how big the fracture, I guess, is. But anyway, Common complications associated with mandibular fracture management: infection, which is infection, delayed union or non-union, malocclusion, facial or trigeminal nerve injury, damage to tooth roots, hematoma, wound dehiscence, and tooth injury or osteomyelitis. Of these, infection is the most common problematic. It is the most frequent complication and is an important cause of non-union. The most common cause of postoperative infection is movement at the fracture site due to mobile hardware, such as a loose screw in an otherwise stable plate, for reasons that a fracture does not heal. 1. Ischemia. The navicular bone of the wrist, the femoral bone, and the lower third of the tibia are all poorly vascularized and therefore are subject to ischemic necrosis after a fracture. Excessive mobility. Healing is prevented and pseudoarthrosis or a pseudo joint may occur. Excessive mobility. Interposition of soft tissue occurs between the fracture ends. And infection. Compound fractures have a tendency to become infected. Important. A fat embolism is most often a sequela of fractures. Inappropriate healing. There's 3 types. Delayed union, which is satisfactory healing, which requires greater than the normal 6-week period, may be caused by infection, interposition of soft tissue or muscle between the fracture segments. Again, delayed union, satisfactory healing, which requires greater than the normal 6-week period, may be caused by infection, interposition of soft tissue or muscle between the fragment segments. This is inappropriate healing. Delayed union. Non-union is a failure of the fracture segments to unite properly. May be caused by infection, improper immobilization, or interposition of soft tissue. And malunion can be either delayed or complete union in an improper position. May be caused by improper immobilization or imperfect reduction. What determines whether muscles will displace fractured segments from their original position? The attachment of the muscle, the type of fracture, the direction of muscle fibers, or the line of fracture. I'd say the direction of muscle fibers. No, the line of fracture. The line of fracture will determine whether muscles will be able to displace the fracture segments from the original position. Favorability is determined by the forces exerted by the masticatory muscles on the fracture segments. A favorable fracture is one that is not displaced by masticatory muscle pull. And an unfavorable fracture occurs when the line of fracture permits the fragments to separate. The 4 muscles of mastication are the temporalis, masseter, medial pterygoid, and lateral pterygoid. After discontinuity of the mandible due to the fracture, these muscles exert their actions on the fragments, leading to malocclusion. Signs and symptoms that may be associated with mandibular fractures: pain and tenderness at the fracture site, changes in occlusion, ecchymosis of the floor of the mouth or skin, crepitation on manual palpation, changes in mandibular range of motion, soft tissue bleeding, sensory disturbances as numbness of the lower lip, deviation of the mandible and unopening, soft tissue swelling, trismus, palpable fracture line intraorally or at the inferior border of the mandible. Approximately 43% of all patients with mandibular fractures have associated systemic injuries. Cervical spine fractures were found in 11% of this group of patients. It is imperative to rule out cervical neck fractures, especially in patients who are intoxicated or unconscious, or in patients who are involved in vehicular accidents. Postural, anterior, and lateral films and CT of the neck should be reviewed with a radiologist before treatment is initiated in these patients. In general, mandibular fractures are less common in children than in adults. When mandibular fractures occur in children, this type of fracture of the mandible, particularly in the condylar region, are relatively common. Simple fractures, green stick, compound, or comminuted. I would say green stick, although green stick is more common in long bones. Well, I guess it is. The ossification capacity of children allows faster healing and distinguishes it from the adult mandible. As a result, many mandibular fractures in children can be treated with immobilization for a shorter time or may simply require observation and a soft diet. Note: open reduction and internal fixation. Open reduction and internal fixation in children are reserved for severely displaced fractures. In an adult, the location of facial fractures is influenced by both the resistance of the bone to fracture and the prominence of its position on the facial skeleton. Adult facial fractures are most common seen in the nasal bones, followed by the zygoma, mandible, and maxilla. In children, early growth in the cranium and orbits predisposes young children to frontal bone and orbital fractures. The following categories classify mandibular fractures by describing the condition of the bone fragments at the fracture site and possible communication with the external environment. Simple divides a single bone into two distinct parts with no external communication. These are closed fractures with no laceration of the oral mucosa or facial tissues. Compound is a fracture that communicates with the outside environment, which is an open fracture. This may occur by laceration of the oral tissue exposed to bone fragments, fracture of the maxilla into the sinuses, or by the way of skin laceration that would expose the fracture segments. Infection is common. Comminuted are multiple fractures of a single bone. They may be simple or compound, and green stick fractures that extend only through the cortical portion of the bone without complete fracture of the bone. Green stick fractures are closed fractures involving incomplete fractures with flexible bone, most often seen in children. Remember, the most common complication of an open fracture is infection. Any jaw fracture extending through tooth-bearing bone is considered an open fracture due to potential tears in the PDL and expose of the fracture to the oral floor.